Hello everyone. So today I'm going to discuss shortness of breath for plab 2. So in shortness of breath, whenever a patient present to you with complaint that doctor, I'm feeling out of breath or I have problem in breathing, the first thing that you need to ask in the history of presenting illness is, can you please tell me a bit more about it? So the open-ended question first, okay? After that, you need to ask about ODPARA. So ODPARA is the onset, duration, intensity, progression, aggravating factors, and relieving factors, and anything else, okay? But apart from ODPARA here, you also need to establish whether it is consistent or episodic. So you need to ask that does it occur all the time or from time to time? So when it is episodic, then you also need to ask about the frequency of episodes and at what time it is more common. Is it more time in the morning? Is it more time in the evening, at night, etc.? Then you need to ask about anything else. So I want you to remember these 5 symptoms on your fingertips, and they are chest pain, cough, fever, leg swelling, and heart racing. So chest pain, cough, fever, leg swelling, and heart racing. I want you to remember these 5 symptoms. And whenever a patient presents with shortness of breath, you need to ask all these 5. Even when a patient presents with chest pain, you need to ask about, just replace the chest pain with shortness of breath. So whenever a patient presents with chest pain, then you need to ask any shortness of breath, cough, fever, leg swelling, and heart racing. Whenever a patient presents with shortness of breath, then you need to ask any chest pain, any cough, any fever, any leg swelling, any heart racing. Okay. So the first 3 symptoms, if they occur, if there is chest pain, if there is cough, if there is fever, then it points out towards pneumonia. Okay. And chest pain basically occur both in pneumonia and in pulmonary embolism. So in case of pulmonary embolism, it will be chest pain, shortness of breath, leg swelling, and heart racing. Okay. Um, Apart from that, you must ask about trauma as well to exclude pneumothorax. And the red flag here is really falls. Okay. So falls means any fever, any appetite loss, any weight loss, any lumps and bumps in the body, and any night sweats. S stand for sweats. Okay. So F for fever, then appetite loss, then weight loss, then lumps and bumps in the body. Lumps and bumps means enlarged lymph nodes, and then night sweats. So if these are positive along with shortness of breath, then it can mean that the patient has lung carcinoma. Okay. You should also ask about any history of heart disease to rule out heart failure. Okay, so basically we have about 4 differentials here. Actually 5 differentials here: pneumonia, pulmonary embolism, pneumothorax, cancer, and heart failure. Also, please don't forget about asthma. So in asthma, in addition to shortness of breath, there will be chest tightness, not chest pain, but chest tightness. There will be wheeze. The patient will tell you that I can hear wheeze or hear some sounds coming from my chest. And in cases of asthma, you have specific triggers. So when you ask the patient, is there anything that worsens it? Is there anything that aggravates it? Then he may give you some specific triggers that yes, it is aggravated by exposure to dust, it is aggravated by exposure to pollen, it is worsened by whenever I am around pets or even cold air. And asthma, the shortness of breath is more severe in the early morning time. Okay. So these differential I want you to remember, and the red flag here is false, which stands for lung fever, appetite loss, weight loss, and lumps and bumps and night sweats, and basically rules out lung cancer. Okay. So after this, you need to ask about past history, past medical history. So past medical history of the presenting symptom. So you will ask, has this ever happened before? And if it has happened before, how was it treated, etc. And then any other medical condition. So as this is shortness of breath, first of all, you would ask, is there any history of heart disease, any lung disease? Okay, and you should also ask about high blood pressure, diabetes, thyroid problem, etc. But make sure to ask any heart disease or lung disease in the past medical history. Okay. Then meftosa. Meftosa is also really important here. So any medications that the patient is using. So for example, if the patient is on COCP, then you might think about pulmonary embolism. Okay. Allergies are really important because in patients with asthma, they have a tendency of allergies, different type of allergies. Okay. Family history, you should ask about family history of lung disease or lung cancer. And so psychosocial here is also very important. So you should ask the patient about occupational history and any history of working with asbestos. Okay, because if the patient has been working with asbestos, it increases their chances of lung cancer. And also if the patient has history of working with organic dusts like silica and if the patient is a former, then it increases the patient's risk of interstitial lung diseases, which also present with shortness of breath. So almost everything is very important here. In lifestyle questions, that is smoking, that is cigarette smoking. C stands for cigarette smoking, and A for alcohol, and diet and exercise. Here smoking is really important. So you should always ask about smoking history in patients presenting with lung problems, or like shortness of breath, which is a symptom of lung problem or heart problem. You should always ask about smoking history, okay? And maybe exercise not that much important, but you should ask about exercise tolerance, how much they can walk without being short of breath, and is it triggered by exercise, because there is a form of asthma that is triggered by exercise as well, which we call as exercise induced asthma. Okay, diet isn't really important here. So then you should ask about, this is basically all about your history taking, and then you should ask about any ideas the patient might be having as to what is the cause of their symptoms, any concerns, any expectations from the team today. And then you should proceed toward examination. So in examination, you will observe the vitals, you will do general physical examination, and you will tell the patient that I will listen to your lung sound and heart sound if that's okay with you. So that was all about the examination. And now with management, I will explain the management of each differential one by one. So for example, your patient has pulmonary embolism and he is presented with shortness of breath. And upon a history taking, he tells you that he also has some chest pain, and there is leg swelling that appeared 1 day or 2 days before the chest pain and shortness of breath. And maybe the patient is on one of these risk factors, okay? So you establish the diagnosis of pulmonary embolism. So you will explain it to the patient that sometimes blood clot is formed in the legs and it moves to the lungs and cause vessel blockage in the lungs. This condition is called pulmonary embolism, and you are having this condition. So why the patient might ask you why I having this condition. Even if the patient doesn't ask you, you will tell him why is he having this condition. So whatever the risk factor out of these, that is oral contraceptive pill, pregnancy, air travel, recent surgery, immobilization, or cancer, whichever risk factor the patient is having, maybe he is having multiple risk factors, then you should tell him that in your case, you have these risk factors that predisposes to this condition. That's why you are having this. Okay, so what is the treatment? So for example, if this patient presents to GP, the pulmonary embolism patient, if he presents with GP, so there is nothing that you can do in the GP for him. So you will directly, immediately refer him to the hospital. Okay. And this patient presents to the ER, then you will admit, okay? So look at the setting. So whenever you are starting a station, please always ensure the setting of the station, whether it is in GP or it is in the ER or it is in some kind of specialist ward. So in the ER, we will admit this patient, we will inform our seniors, and then we will do some investigations that will include routine blood tests, clotting profile, ABGs, D-dimers, and CTPA. Okay, no need to remember well score, because well score, like an exam, you will have a clear-cut patient of DVT. So you don't have to memorize the well score. They won't give you a vague patient where there will be another likely diagnosis and you might need to apply well score or stuff like that. Your patient will be very clear cut. One or two risk factors will be there, clear cut history of leg swelling and symptoms of DVT, symptoms of pulmonary embolism. So don't bother about remembering well score. Okay, so we will investigate here the the diagnostic investigation basically is CTPA, which, well, you will tell the patient that I will do a chest scan, which is called CTPA, to localize the location of the blood clot, which is called vessel blockage. So treatment will be, in symptomatic treatment, we will give 100% oxygen to the patient. We will keep the patient in propped up position. And in specific treatment, we'll give the patient heparin, we'll tell the patient that we are going to give you some blood thinner that will prevent further formation of clot. And so initially we will give him through the vein and then followed by subcutaneous heparin. Safety netting, as we are admitting this patient, so we will tell him that there is a bell under your bed that you can press in case your condition worsen, and one of us will be around. Okay, so in case of admitted patient, your safety netting is just telling the patient these lines. Okay. All right. So now in heart failure cases, you need to explain it to the patient that, so now the heart failure patient will have shortness of breath. He will not have so much of chest pain. He will have leg swelling, like both leg swelling. In pulmonary embolism, the patient will have swelling and cough of one leg. It will be unilateral. But in heart failure, the patient ankles will be swollen and it will be on both sides. And the patient will have history of previous MIs. And the patient will tell you that he's taking medication for increased blood pressure and heart problem, etc. So you will tell the patient, you will explain it to the patient that your heart is weak and it is not able to pump fluid out of the lungs because of the previous heart disease. What you are going to do for this patient, you are going to either admit or observe, depending upon the severity. You will inform your seniors and you will do some routine blood test. You will do an ABGs, ECG, chest X-ray, and heart scan. Heart scan is basically echo. Treatment, so symptomatic treatment will be keeping the patient in propped up position, giving him oxygen, giving the patient, telling the patient that we will give you some medication through your vein, which is called diuretic, and it will remove fluid from your lungs and it will ease in your breathing. We'll also inform our seniors. Specific treatment here is cardiology review. So we will tell the patient that we are going to arrange a review for you with the cardiologist, and they will give you some medication to reduce the stress on your heart. So basically, cardiologist will give him blood pressure lowering medication and beta blockers to reduce the stress on the patient's heart. Safety netting will be the same as above because we are admitting this patient as well. Now, asthma. So asthma can now present with, the normal asthma patient, the newly diagnosed asthma patient, or the normal mild asthma patient. But asthma can also present with severe asthma, status asthmaticus, or moderate to severe asthma. So in severe asthma, the patient can't really talk. Okay. So he's not able to, like, it's one of the signs of severe asthma, moderate to severe asthma, the patient is not able to talk properly, and they can't even complete the sentences. So it's difficult to put such a patient in a history taking or diagnostic medicine station where you need to elicit a history and you need to um, do examination and come up with a agreed management plan with the patient, because it will require the patient to talk. So in severe asthma cases will be in Simon, and I have covered how to how to manage a severe asthma patient who might come as Simon and what is the protocol there. So I have already discussed it in the Simon station, and I will also put the link in the description. Here we are going to talk about the patient who has mild asthma, maybe newly diagnosed or something, and he has walked on his feet to the clinic and he can talk and he is not in that severe condition. Okay, so you will explain to the patient that asthma is a condition in which the airways become narrow and they swell and cause breathing difficulties. Why this happens? Because this runs in the family, so it is genetic, it has some genetic factors, and it's also triggered by various environmental factors as well. So what is going to be the treatment for this patient? So obviously, if severe asthma, then if we are in the GP, then we are going to refer. If we are in the ER, then we are going to admit. But this is not the severe asthma patient, okay? So we don't need any referral. We don't need any admission here, okay? We just need to inform our seniors, and investigation should be routine blood test and a chest X-ray and pulmonary function test with bronchodilator reversibility testing. So the management here will be symptomatic and specific. So symptomatic will be blue inhaler. So blue inhaler is basically, blue inhaler are basically the beta agonists, okay, salbutamol, etc., which are going to, which provide symptomatic relief. So blue inhaler will tell them that if in case you experience any shortness of breath, then you should take 2 puffs from the blue inhaler, okay? So blue inhaler are not, the regular medication. They are only used as required. So whenever the patient experiences shortness of breath, then they will take 2 puffs from the blue inhaler. We'll tell the patient to maintain an asthma diary and to note the time and the duration of the symptom and the triggers as well, okay? So maintain an asthma diary, and whenever you come for your next visit, then please bring the diary, and we will, so in this way, we'll able to monitor the severity and frequency of your attacks and the triggers as well. Avoid any known trigger like pets, carpet, cold air, etc. So specific treatment here is brown inhalers, which are basically corticosteroid inhaler, and these inhalers the patient has to use daily. Okay, so corticosteroids, they basically reduce the inflammations in the airway. So they are specific, and we will tell the patient that please keep this brown inhaler in your washroom. So whenever you take these, take a puff of this inhaler, rinse your mouth after that, because if you don't do it, then there is a risk of fungal infection of the mouth. So please remember this point as well. So tell them that keep this in the washroom. So whenever you use this inhaler, you will remember to rinse your mouth as well. Okay. Safety netting should be about status systematicus. So you should tell them that if you experience severe shortness of breath and that is not resolving with blue inhaler, then please call 999 or come to the emergency department. Okay, follow-up here should be 2 weeks and tell them to bring their asthma diary with them. Okay, now pneumonia. Pneumonia, the patient will present with fever, cough, and shortness of breath, and chest pain as well. So we'll explain it to the patient that it is an infection of the lungs. Okay, how we are going to treat this? So treatment will depend whether to admit or not. It will depend upon the something that is called a CRB65 score. So CRB65 scores, the C stands for confusion, R stands for respiratory rate, and B stands for blood pressure, and 65 stands for the age, which is 65. So if the patient is confused, then it means that we have 1 point. If respiratory rate is more than 30, then we have 1 point, otherwise we have 0. If the blood pressure, if systolic is less than 90, then we have 1 point, or otherwise it will be 0. If the diastolic is less than 60, then we will have 1 point. If it is more than 60, then we will have 0 points. And if the age is more than 65, 65 or above actually, then we will have 1 point. And if it is less than 65, then we have 0 point. So if all these points you have 0, then you will refer this patient, then you will discharge this patient in home, like you will not admit or observe. If the score is 1, so for example, the respiratory rate is high or the patient is 65, but everything else is normal, then you will keep the patient under observation. Okay, if this is 2, so for example, the respiratory rate is high and the patient is 65 or above, you will keep the patient in ward. Or if the score is 3, that is, the patient has high respiratory rate, low blood pressure, and he's 65, then this means the score is 3, you will admit this patient to ICU. So basically, this score refers to mortality, and when the score increases, the mortality also increases. Okay, so whether to admit or not, because this score is really simple to apply, because all the points are clinical: confusion, respiratory rate, blood pressure, and the age. You can, just ask the patient, or you can find respiratory rate and blood pressure during examination. So it's easy. So you will decide based on this score whether to admit or to observe or to send back home. We'll inform our seniors. Investigations will be routine blood tests, that is CBC, LFTs, RFTs, etc. Of course, a chest X-ray, sputum culture, and blood culture. Okay. Symptomatic treatment here will be oxygen, paracetamol, and IV fluids. And specific treatment, of course, is an infection. Specific treatment will be antibiotic. You don't have to remember the name of antibiotic for plab 2, except for the STI cases. So you will just say antibiotics according to the hospital protocol, and then you will safety net the patient. If the patient is having severe shortness of breath, or he's not able to breathe properly, or he's feeling dizzy, or the fever worsens, then call 999 or come to the emergency department. And follow-up should be at 2 weeks. Also, so follow-up in this patient will be at 2 weeks. And all right, so this was all about shortness of breath, and I will see you in the next video. And also, I wanted to tell you that pneumonia can also present as a Simon case. So if this is severe pneumonia, then it will present as sepsis due to pneumonia, and that will be a Simon case, because the patient will not be able to not be so much oriented, and you will not be able to elicit a proper history from that patient. Then that will present as Simon. And I have also covered the Simon sepsis station, and I will also put that link in the description. And I will see you soon in the next video.